our bodies are designed in a way where we are prompted every month that you can conceive, you can conceive. Now, for those women who decide that they do not want to conceive, they don't want to have a child, what does their body go through?
Like if you're over 35, then you're considered a geriatric pregnancy, which is almost.
Could you be any older?
Could you be any older? But are there anything that women over 35 need to specifically look out for more?
Like there are also different types of pelvises. Not everyone has the same term. There's a gynecoid pelvis, an android pelvis. Pelvis are also different types.
So some pelvises have less pain. Some lucky
they're more.
people.
They're more.
What's the one that has the least amount of pain?
Gynecoid
Which one
pelvis.
do I have?
How do we get to know which
How do we get to know? Is it by the size of the hip?
Yeah, there are a few ways in which a doctor can tell.
Twerk best?
So there are different.
How did people give birth before like medical advancements?
Oh God!
That's
I'm getting stressed.
Yeah.
Hi everyone, and welcome to another episode of Don't Run Into Glass, a podcast hosted by thecitizen.in. I'm Gayeti.
And I'm Anica.
And Anica, what are we chatting about today?
Today we're talking about female health. We're a bunch of girlfriends talking to our favorite kind of doctor, a gynecologist, about all the questions that we could never ask a gynecologist.
Yeah, and I'm really excited actually for this conversation because I have been, and you know I'm a hypochondriac, so you know I have a million questions.
Gayeti is a hypochondriac who was convinced that she had gangrene on her toe when she just stubbed it against a table.
I went to the emergency.
She went to the emergency room at 2:30 in the morning.
And this pregnancy, I thought I have pre-eclampsia. I thought I had leaking amniotic fluid. So I've really imagined every single possible symptom. And sometimes I just feel so stupid asking my actual OBGYN about this. So I'm glad we have with us Namrita in the room, who I can unshamedly ask these questions without any fear of judgment.
By the way, we just had a 45-minute long conversation with her about all our personal questions, and we're like, okay, let's start talking now.
Yeah.
Thanks, Namrita.
Yeah, hi, I'm so glad to be here.
Yeah, we'd just like you to introduce yourself. So you're, how long have you been practicing, and yeah, just sort of a little bit about yourself.
Yeah, so I'm Dr. Namrita, and I've been practicing since the last 12 years. Right now, I'm a consultant working in a hospital in Delhi, and I think I'm very passionate about my field because it's just so, other than all that gynecology involves, the fact that you can make a difference in people's life, especially women, and educate them and talk about because I think gynecology is so much about, like, when a patient comes to you, it's not just their health. They talk about their mental issues, what's going on in their lives. So along with being a doctor, you're also a healer in some way. That's something I really enjoy about my profession.
You're the only healer I believe in. If someone comes and tells me I'm going to perform Reiki on you and your headache will go away, I was like, no, give me a combi flam.
No, but honestly, I feel like gynecologists and even pediatricians to a degree, they are like almost therapists.
Yeah.
Especially because you're dealing with people who are either struggling to conceive or new mums whose hormones are all over the place. Because I remember after my daughter was born, for the first 1 week, or when I went in for my 1 week checkup, and my doctor asked me how you're doing, I just started crying. I don't know why I was crying. Yeah. And she was actually just like, this is normal, it's just your hormones crashing, they built up over the pregnancy, just relax, you'll be fine in a week. And I was fine in a week, there was no more crying or anything.
And so many times I think women just need somebody to listen to them.
Yeah.
So sometimes they come to you just because they want to be heard. Of course, there is some underlying issue which is there. But more than that, it's also about how you connect with your patient. Whether you're able to give them the confidence that they can confide in you, sometimes about very intimate issues also. So I mean, I think it's great when you're able to make a patient feel comfortable enough to discuss issues that are so personal to them. That's something I really enjoy about my profession.
They're probably telling you things that they haven't told, like their family members or their
friends. Their partner, for that matter.
A lot of
partner. Yeah. So that trust is.
Though I do encourage open communication between partners, especially because I think it's very, very important. That is the foundation of any relationship. But yes, so this is something I really enjoy about my profession.
Yeah, I mean, I feel like to be in the medical field, you have to really love your profession, because obviously it is grueling, like the timings, and which is why we're so appreciative of the fact that you made this long drive.
She just did a night shift the night before. So thanks for coming.
Thank you for coming.
Drive, but my pleasure. I'm so happy to be here.
Yeah, so we have tons of questions for you. We wanted to sort of like just go through the trajectory of, let's say, women. Starting with maybe like, sort of just taking charge of our own fertility, right? So let's say that as a gynecologist, do you have any tips for, let's say, somebody who is maybe still like, teenagers, hit puberty, isn't really even thinking about their fertility or anything of the sort? Is there anything they should be thinking about at that age in terms of like lifestyle choices, diet, nutrition, anything to preserve their fertility in the long run?
So I think that's a very good question. So at the outset, what I would like to tell everybody is that yes, so most women have this concern that with age does the fertility decline. So what I wanted to tell you all is that yes, the moment a child is born, a girl child is born, all the eggs that she's going to release throughout her lifespan, they are there, in her body at that time when she's born. And when you hit puberty, that's the time when you start having your periods. That's the time, every month you release one of the egg. One egg from, every month one egg is released from either of the two ovaries, right? So obviously, so the older you get, you're releasing an older egg. It's an old egg that you're releasing. It's from the pool of eggs that you have, you're releasing an egg, right? So the older you get, you're releasing an older egg from your system. That is true. So the thing that you can take care of from early on is what I would say is good exercise, a good healthy exercise routine. You should be point on with your nutrition and just leading a stress-free lifestyle where you follow a nutritious diet and a good exercise regime without putting undue stress on yourself about like anything. Like
how in a world of work targets and Zomato, it's close to impossible.
Yeah, especially with today, when I see young girls and how even us, we've become so used to ordering food from outside, and so I think that's something from a very young age which mothers or as parents we need to probably also change our own dietary habits, because I think children also learn from what they see at home. So I guess if we make it a routine or a habit to maybe encourage good healthy habits, eating healthy. So that's what the child imbibes what they see, right? So if you make that a kind of if they see the parents eating healthy and you have good healthy food which is yummy and nutritious at the same time, So if children get into that habit, like I as a child, maybe I don't think I ever really had Coke or cold drinks till I was maybe 15, 16. We never had that at home. We would drink the age-old nimbu pani made at home.
Yeah.
Did you have rasna?
Yeah, like Campa Cola was a luxury, It didn't really come about.
But so these days I see that is the reason the obesity is so high.
Yeah.
So all that, so children, and especially now with the phones, children being so addicted to their phones, there's hardly any physical activity.
Yeah.
So we need to encourage not only young girls but even boys. We need to encourage them to be more active, eat healthy diet. So unnecessary stress, I wouldn't say that you need to put unnecessary stress about fertility.
Yeah.
It's more about a healthy lifestyle. Start young. Make sure that your children follow a healthy lifestyle. If they're healthy, they'll be healthy in every way.
And I think a healthy lifestyle is important from the sense that like those habits that you inculcate at that age like will hold you in good stead later on as well. So if you're used to eating well and eating nutritious food,
good immunity.
Good immunity.
So that will help you not only it will help you in every sphere of your life.
Yeah.
It's not just good fertility is just one of the byproducts of being healthy.
And I want to also point out, because I've read this many times and now only like fertility, pregnancy stuff comes up on my Instagram feed, but I've read that like male health is also very, very important towards fertility and conception. So there's this sort of perception that it's all, you know, on the woman and it's her fertility. But apparently if like the father is not very healthy, then
or
that
even
can also
a smoker,
impact
that affects
smokers, being overweight.
or underweight and just like completely lacks exercise.
How true is
Definitely.
that?
Yeah, that's very true. So there is also something as male infertility. So if we talk about even the causes of infertility, the most important cause is unexplained. Unexplained infertility is the most important cause of infertility, or the most common cause. I would like to correct myself. The most common cause of infertility, unexplained infertility, where both the partners are healthy, but yet they're not able to conceive, right? So because of unexplained reasons, that's unexplained infertility. And the second most common cause of infertility is male infertility. So male infertility is commoner than female infertility. It's just that it's not addressed so much, right? So smoking, heavy smokers, and alcoholics, which does not mean that you can't enjoy an occasional drink. You can, but I'm talking about, you know, hardcore alcoholics, obese people, smokers, so all, and not exercising enough. So all these factors do contribute to male infertility, which is an important contributor to infertility.
And this unexplained fertility, do we have any reason like what could be the causes for it, or is it just like
that's why it's unexplained?
No one knows. It's like literally, it's just a couple that is unable to
conceive despite everything being normal.
Yeah.
And I think in that unexplained segment, stress plays a very, very important role.
Correct.
Like with everything in life, stress is a major contributor to, I mean, you could put it to any disease. You know, these days the whole mind-body game, you know, how powerful the mind is.
Yeah.
If you're stressed out, you know, you could have symptoms like, you know, we were just discussing how
my array of symptoms.
Yeah. So, you know, undue stress can cause varied symptoms. So stress is the main factor. You know.
Yeah, and I think our lifestyle is also, I mean, we're all now a lot more stressed than maybe our parents' generation was.
Yeah, because everyone's competitive, they want, and also this generation where you want easy gratification and you're so impatient, and so that, which is not helping. Yeah. Right, in any way.
In fact, what you said to Anica, I think is really useful, because we were sort of like talking, and Anica said that, you know, you're going to be obviously trying for a baby soonish. So you wanted to do all your tests, and your advice was...
it's like a classic question, because like I'm 36 now, and all our life we've been conditioned to imagine that that's late. That's really late. So my question to you was, you know, how do I do? But carry on.
Yeah, and so you said that don't bother with the tests. Just sort of like try. And if for some reason it doesn't happen in 6 months or a year, then you start worrying about the tests. Because what the tests, and this has happened to my friends who've not even started trying. They've done tests and they've seen that the AMH is low, or, you know, some reading is not right, or whatever it might be, and then they get paranoid and very, very stressed about that. Whereas if they didn't know, they probably would have, you know, not even thought about it.
Yeah, even conceived.
Exactly.
So, you know, having said that, like I said at the outset, that, you know, of course, age plays a role in your fertility game. But yes, but that's all right. Now we know that you're 36, which is fine. Of course, the best fertile period for any woman is, of course, like 21 to maybe, you know, 34, because the older you get, we're releasing the older egg, of course, and the quality of the eggs could go down. But the thing is, 36 is not that old also, as long as the cycles are regular and you're not experiencing any other, you know, menstrual issue. Your cycles are regular. It means that your hormonal milieu is somewhat normal. Yeah. You're not experiencing any symptoms, so out of the ordinary. So you should try and conceive. You should try to get pregnant for about a year. And if you're not able to get pregnant, that's when you should start investigating yourself.
But you know, I wanted to ask one question now that I'm reaching the age of 30, like on the other half of the 30s. A common thing between me and my girlfriends that we talk about is like, we have started feeling our hormones in a much more significant way, you know. Now, also it's like, for a long time for women, oh, she's hormonal, oh, she's PMSing. You know, these are commonly used terms. Sometimes it's offensive and sometimes it's actually true. You know, it's sometimes all those memes on the internet hit hard. It's like, now I know why I was bawling my eyes out because 2 days later I, you know, started my period. So I want you to talk a little bit about and sort of tell like people of all genders about what does this hormonal action in a woman's body mean, and as they grow along, how does it evolve, and how to be okay or understand it better, you know?
So, to be honest, this whole change in hormone and how hormones affect our mood and sometimes, you know, so if we are cranky or if we are in a bad mood, definitely our hormones are acting up, and you know they do play a role in that. So there's no denying that, right? And
sometimes it's so unfair. It's like, I want to be in a good mood. It's like great weather outside, but I hate everyone.
Yeah, but that is true, because you know there is a fluctuation in your hormone levels throughout the menstrual cycle. That's how we as women are designed. Some women feel it more, some don't as much. Just like, you know, so many women, I've had friends who've had so much of dysmenorrhea, like when you have pain in your periods, painful periods. So to the point that, you know, they had to skip school because of that.
Yeah.
And there are women who've never had, you know, a problem with their periods, you know, no pain, nothing. They would be playing basketball, being very active during their periods. So that is a variation which is seen. But, you know, having said that, yes, hormones do play a role. They affect our mood. You know, PMS is real, premenstrual syndrome.
It is so real.
Yeah, but it's not that everyone gets it. Why we get it? Of course, because of the hormones, right? Sometimes we feel low when we're about to get our periods because there's a dip in the hormones, and that's because you're going to get your periods. So all that affects your mood. So you just have to identify that, you know, it should, so a little bit of hormonal, like, you know, a little bit of emotional instability is all right, you know, because you can control it just by being more in control of yourself. But if you feel it's bothering you to a point where it's affecting your daily activities, that's when you should see a gynecologist. Because there are medicines that we can prescribe. Once we get to know what your symptoms are, we can prescribe medicines which will help you get over it. So you don't have to suffer. The idea behind this is that yes, these things are real, we can't deny it, hormones play a role, but you need to get yourself treated if you feel it's impacting your daily life.
So is it true that because of these hormones, every month we have just one good week?
No.
Not really. There are very few women who would qualify, who would, you know.
It's like your body is preparing, your body is ovulating, your body is in the period thing, and when the period is over, then it's like the one good week that comes that nothing is happening. Your body is just like, I've done it all.
No,
and then
stuff is happening. Your body is sort of like then getting rid of, preparing to get rid of the lining and the eggs.
So there's not
even
a single good week. Is that what you're telling me?
So there's a very interesting story which was there in the book, which was like, you know, so every month the uterus prepares itself to receive the baby, and the uterus is planning and preparing, and because every month when the uterus does not, you know, the baby doesn't get implanted, the uterus weeps, and that's what we see as the menstrual blood. You know, so
looks like a story my grandma told me once.
I know. Yeah, but then this is kind of true, but then, you know, there are very few women who actually you know, have these hormonal issues to a point where it's actually impacting their lives so hard.
Yeah,
but otherwise,
just listen to a good song and have a drink. Yeah, you'll feel better.
Yeah,
you know, sometimes it's just like nothing can tame me, and do not cross me. Like
I think it's a blessing to be born as a woman. I mean,
100%.
Yeah,
it is magical.
Oh, but there's one really annoying part, guys. I have to tell you this. It's like with Isla, like my daughter as well. Like, I mean, I carried her, right? Then I fed her. I had the sleepless nights, everything. And like, honestly, when she came out, everyone, and till today, everyone just tells me, oh, she looks like exactly like her dad. And it just frustrates me to no end.
I have patients who say the same thing. They're so irritated when somebody says that.
But like the other day, Gayeti came back after an ultrasound and she said, the doctor tells me that this child too is looking like the dad. And I was like, how can the doctor tell me?
No, he said that to me, and he also said just accept the fact that you're a luggage carrier for your husband's genes.
Oh God!
I was like, this is brutal. This is so brutal. But no, I think he just meant generally, like just
he was.
But you know also that when children are growing up, their face and it keeps changing.
Yeah.
You know, so she must be still young. How old is your daughter?
She's 2.5, and she's already looking more like me than she did like till a few months ago. So, but no, I'm just joking. It actually doesn't really bother me, but it is so unequal. Like, you do think about the fact that, like, as far as the biological process is concerned, the burden is on the woman, right?
True.
Like
Yeah.
in terms of conceiving, even, you know, carrying your child, birthing your child. Like, I mean, labor is like another story altogether. And then even the postpartum period. I mean, the father is, of course, involved to whatever degree that they can, but the bond between the baby and the mother, and the fact that you're the one who can feed the baby, it's all very, like, the onus is on the woman.
On the woman, I agree. But I think here, one thing I would like to say, that antenatal workshops play a very important role. I don't know if you're in your first pregnancy, you attended any antenatal workshops, or if you're attending now.
Yeah.
Because, you know, so we at our hospital have these antenatal workshops where we make sure that both partners attend the workshop together, where we explain what the woman is going to, especially first-time mothers, because they have no idea what they're in for, and what they're going to experience during the pregnancy. So we try to explain them a few symptoms which are normal, and if they're having it, they don't know how, you know, they can tackle with a few symptoms themselves at home also. And we also explain them about labor. Once they go into labor, what should they expect?
Yeah.
And you know how it is. We teach them a few exercises, and we also, so it kind of also is very informative for the fathers to be.
Of course.
And I've seen a lot of, I find these men to be far more empathetic, and the whole experience, especially for the woman, is much better because the male partner is so involved during delivery. And I think the woman also feels somewhere very, it's very comforting.
Yeah.
You know, when your partner is
of course.
that involved.
So,
Yeah.
I mean, of course, I'm not trying to like sort of mitigate the father's role. It is very, very important. And for a woman,
to be honest, I think women are far stronger than men, because, you know,
100%.
especially even during labor, I've seen that women are, some of them, they're really strong, and they're like in the act to, like, you know, they're okay, we'll do it, we'll push. And the men are like, you know, if you look at them, you're like, you know, they might just collapse. And you know, some of them are so heavy, you feel, I've
heard these stories of like the father
if you
collapsing.
collapse here, I don't think, you know, I'll be able to handle you.
And also, I think even the labor and delivery rooms, like, they're a very like powerful female energy, because usually your doctor, I mean, not in all cases, but at least in my case, like, the doctor was also a woman, the birthing staff and the nurses were all women. So it is a bunch of women, like, kind of like just cheering you on to like have the baby and push and, you know, be able to have that birth. So that is also like a nice like little tribe, and, you know, a very empowering experience.
True.
That's the positive side of it.
And here also, I feel that even during your pregnancy, if you're physically active, you're doing your squats and lunges, I mean, of course, under supervision.
Yeah.
Because, you know, I wouldn't recommend you to exercise on your own without supervision. But if you have somebody guiding you and trying and tell you a few exercises you should do, even yoga or whatever form of exercise that you want to do, that also really helps in normal vaginal delivery.
So this is also a question, Anica and I were actually talking about this before as well. There's been a huge rise in like C-sections, not just in urban cities in India, but like across the world. And, you know, there's that myth that like, you know, rural women don't have so many I don't know if this is a myth or a fact, but obviously rural women have more natural deliveries, and that's maybe because they squat
so
more and they're
labor.
like, you know, they're physically fitter, for lack of a better word. But is there a trend for hospitals to push you towards C-sections as well? I don't know if you're actually allowed to really even speak on the subject or not. But why are we seeing such a rise in C-sections is basically my question.
I'll only speak about myself. I wouldn't like to comment on other people and what they practice. You're right that in some hospitals, even I've observed that there is an increase in the rate of cesarean section. Sometimes cesarean section is actually warranted, and you actually need to do it. And and that's the time when sometimes patients don't understand, and they feel, oh, doctor is just doing it because, you know, for their own interest or whatever reason. But there are a lot of times when it's actually indicated and you need to do it. So
and what would be those times?
What are those times? What are those situations where the patient, if the doctor says that, like, just listen to the doctor, you know? Yeah.
So, so they could be, so some are out and out absolute indications where you won't even consider vaginal delivery. Like if you have, it's a case of placenta previa, that your placenta is, you know, overlying the cervix, there's no way that you're going to deliver, right? So either that, or if it's a breech presentation or a malpresentation. You know, it's not that the head is down.
Yeah.
Right? So there are a lot of indications like that.
Malpresentation means the baby is the other way around?
Yeah.
It could be a transverse or a breech presentation. So first time, even though these days the trend is even for primary first time mothers who have a breech, generally they go in for a cesarean section.
Yeah.
So a lot of absolute indications where, you know, there's no question. And for that, patients are generally prepared.
Yeah.
But sometimes, you know, if you're in labor, again, then there are some emergency conditions. You could have a cord prolapse.
Yeah.
Or a rupture.
What's a cord prolapse?
The umbilical cord, sometimes when you rupture the membrane, the cord may slip out.
Ah, okay.
Or even otherwise, sometimes, you know, if the head is
Prolapse
not fixed.
means that it's not being held into place. It's just
it comes out from the
lost
vagina. It comes out. So that's an absolute emergency. You know,
Yeah.
It's also causes a lot of obstetrician distress because you need to immediately shift the patient.
Yeah.
And you have to deliver the baby. You don't have too much time. You know, so those indications, even patients don't contest because, you know, they can see how urgent it is. But so many times, you know, if you see the patient, baby may have pooped inside.
Yeah.
You know, it's called meconium.
Yeah.
There's thick meconium with CTG changes. So during labor also, we try and monitor the baby's heart rate.
Yeah.
Right? And it's a graph that you take out, which is like a representation of the baby's heart rate, right? Just like an ECG, an adult ECG. So that's the graph that I'm sure.
I was strapped to that thing, which was really annoying actually.
Yeah, there's a belt that's tied across your
Yeah.
umbilicus and they're tracking the baby's heart rate. Yeah. So if there's any abnormality in that, so there could be some abnormalities that you can still deal with, but if it's really pathological, you take a decision for a cesarean section and shift the patient to the OT.
Okay.
Yeah, so there are certain indications like that where sometimes, you know, you tell the patient they're not convinced about it and they want to still think about it and say, oh, we want to take our time, we want to think. But mostly patients trust the doctor and you know, if you tell them that, okay, this is really needed.
I feel like anytime I'm in pain and a doctor's in front of me and a doctor says, do this, it's like, yes.
Yeah, but so, you know, I've had friends that have given birth in the US where the doctors are not actually really allowed to tell them point blank what to do, whereas here it's different. You know, here if your labor is going on for too long or they feel like the baby's in distress or something of the sort, they can very clearly just tell you, listen, it's time for a C-section. But now, like with new rules in the States, for instance, it's harder to do that. So I had a friend who was in labor for a long time. Her baby was very large and clearly the doctors wanted a C-section, but they didn't know how to like say it. So she actually suffered a very long labor.
And ultimately
she had to have a C-section. Yeah. So does that also play a role in deciding whether you should have a C-section or not? How long your labor has been?
You can't say. So, you know, a lot of parameters play a role.
Yeah.
You know, a lot of, you know, so it's a passenger, which is the baby, the pelvis, and the contractions, how you get it.
Does the size of the baby matter?
Yes, it does.
Okay, because in her case, it was a large baby
so if,
as
if
well.
the baby is like 4 kilos or 4.5 kilos, you know, if you're trying to pull out that baby vaginally, you fracture the clavicle or you know, the baby, and there's a huge risk of shoulder dystocia, which is a total obstetrician's distress where the head of the baby comes out and the shoulders get stuck inside.
You know, how did people give birth before like medical advancements?
Oh God.
That's
I'm getting stressed.
It's more stressful for the doctor, imagine, because the doctor there is responsible for 2 lives, you know.
Yeah.
So I would definitely still say trust your doctor because, you know, they're actually more scared than you, or scared or concerned is the right word for you, because, you know, they're responsible for 2 lives.
Yeah. Which is also probably why many err on the side of caution and why there are more C-sections, right?
And, exactly. And especially with the with how strict, you know, the legal system is, and you know how, and even patients, you know, sometimes they change their statements and it becomes it's you know, everything is on on you. So I think doctors are also sometimes not wrong in taking that decision. You know, and I think only if you're in a big hospital where you have a whole huge support staff are you able to, like in our hospital, we're able to take that call, we're able to really try for a normal delivery, is because it's a very well-equipped hospital where we have a lot of doctors, you know, we have a concept of group practice, so it is, we're able to manage that. But there's some people who are working on their own in their small nursing homes, it becomes very difficult for them to take that call.
Got it.
I guess one of the questions I also wanted to ask is that, you know, there are a lot of women out there who do not take the route of making a family or even conceiving for that matter. And our bodies are designed in a way where we are prompted every month that you can conceive. You can conceive. Now, for those women who decide that they do not want to conceive, they don't want to have a child, what does their body go through?
So I think so one thing that so there are two aspects to that. One is if they're not ready for pregnancy yet, and in future they would want to conceive, they can obviously go for egg freezing. They could freeze their eggs. That's one option available to them in case they want to go down that route. And the other thing is if they don't want to conceive.
And what's the best age to freeze your eggs?
Again, you know, that the earlier you do it, the better.
Right.
You know, so because again you're taking from that ovarian pool which is already there, right? So the earlier you do it, the better it is. So maybe before 35 would be a good age. And the other thing is that if you choose not to conceive, so I think it's a very personal choice. And these days, a lot of women, a lot of married couples I see who are planning not to have children, and they're okay with it.
Yeah.
Yeah.
So I think if you want to go down that route, that's also fine. It's not that you're going to experience.
From the perspective of like,
it's not that you're going to.
Hormones are, you know, hormones are acting a certain way. Does your body go through changes
Not
that
really.
you must be aware about?
In the sense, just because you choose the two females, one female chooses to get pregnant, the other one doesn't get pregnant. It's not that the hormones are going to, you know, act up differently in the one woman who chooses not to have children. When they're perimenopausal, when they're in that age, of course, that even a woman who's had children, even her body is going to act up and, you know, have those symptoms. But then having said that, also there's so many women who have a very smooth transition to menopause. They have no symptoms at all. And there's some women who have a lot of, it's very complicated for them.
Yeah.
So again, it's very difficult to predict and to, you know, oh, you're going to have it's going to be difficult for you, the whole transition to menopause. You can't, you know, it's only when you reach that stage, you know how easy or how difficult it was for you.
Yeah, no, and I think that was an interesting question because I know a lot of like, again, friends of mine who've chosen not to have children and they do think about this. They're like, you know, is it going to like impact like my health overall? Does it make me more prone to, I don't know, breast cancer, ovarian cancer, or like, you know,
so there
things
are
like
certain,
that.
So there are certain cancers that you are, but then that you're more prone to. But the thing is that, you know, that risk is very small.
Yeah, exactly.
So we're also, by saying that, trying to put unnecessary fear in the minds of people. They feel, oh, since I did not conceive, oh, am I prone to this? So I don't think you really need to start Googling.
It's a very marginal
it's a very
increase.
marginal increase.
Yeah.
It may never happen also. So you don't need to, I feel, unnecessarily
worry too much.
Yeah, worry too much. Like we said, stress is, you know,
that's probably causing it. It's not like you not having a child. It's like,
I think so that's more important. So we don't need to. It's a very marginal thing. So I feel in today's day and age, being stress-free, making good lifestyle choices, is more important than worrying about unnecessary. That's where our focus should be.
And like now, there are, in a gender fluid world that we live, there are several people who've transitioned to becoming a female, a woman now. Who do they go to? Do they also come to a gynecologist? And can they conceive? Like,
so that's a very so yes, they should come to a gynecologist, but somebody who's had a sex change operation, let's say, it's just the genitalia which is going to change. They don't have the so first of all, even in transgenders, there's a lot of varieties. You need to check like what it is, but if they don't have the internal organs, they don't have a uterus, they won't be able to conceive.
In fact, there have been cases of like women who've transitioned to men, and like as men, they have gotten pregnant, and they've of course delivered babies.
Of course, yeah.
It depends because if they have the uterus.
Yeah, they have the uterus.
Yeah, so it all depends on that. And that requires a lot of, sometimes you need to give external hormones.
Yeah.
So that's again a very...
and this is not really a gynecologist department, right? Like it's another medical department?
So some of the patients have to be seen in consultation with an endocrinologist.
Got it.
Yeah, so it is, it's kind of becomes multi-speciality. So you involve different specialities and then treat such a patient.
Got it.
And also sometimes we need to take help of a psychiatrist because these people also go through a lot of mental health issues or sometimes emotional issues. So you need to involve doctors from different specialities to take care of that one patient.
Absolutely.
Got it. Also, question like now, you know, we also joke about this amongst our friends because we're all over 35, and like if you're over 35, then you're considered a geriatric pregnancy, which is almost.
Could you be any older?
Could you be any older? But are there anything that women over 35 need to specifically look out for more? Like, for instance, I had a friend, and this didn't happen to me. We're both over 35. She was just prescribed blood thinners immediately, and the gynecologist said that that's protocol. If you're over 35, you're just going to get blood thinners. That's not the case that I had. But what are the things that maybe like older, for lack of a better word, women need to look out for when pregnant?
Yeah, you're right. So books do mention that, you know, so at 35 you may think that we are young. When you are young, I don't think there is a age really defines a woman that way. But yes, if you want to get pregnant, even books mention, oh, you know, so now you're an elderly gravida.
How rude!
You may not think of yourself as elderly, but that's how it is.
I'm not buying that much hair color.
Anica, you can't say this with your grey hair on your head. Okay, first you dye your hair, then we'll talk about it. Yeah.
But then, you know, the truth be told that yes, like a lot of things like hypertension, diabetes, so the risk of complication does go up.
Yeah.
You know, the older you are, there is a risk factor. I mean, it is a risk factor. And the complication, the medical disorders of pregnancy are seen more in women who are older. But then again, I don't want to stress out women.
Yeah,
you know,
because again, the increase is marginal.
There is definitely there's an increase, but then not so much, and it can be easily managed. So the idea is to have to have a pregnancy that is well supervised, have regular hospital visits, and let your doctor diagnose those things.
Yeah,
because you know it's not.
Don't Google them.
Yeah, don't Google them, and also. See, problems happen even with blood pressure. It'll happen when it becomes uncontrolled.
Yeah.
Similarly with diabetes, you know, there's also something called gestational diabetes. Just because you're pregnant, you become, because pregnancy is an insulin-resistant state, right? So you could develop diabetes just because you have become pregnant, and you were never diabetic earlier. It's called gestational diabetes mellitus, because you're pregnant, you've got diabetes. And once you deliver, your blood sugars become normal. But yes, once a lady has diabetes, she has a 50% increased chance of developing diabetes later on in life. But for that, you can be a little bit more careful.
Like a minefield, this body.
But you might not get gestational.
Yeah, you may not. It's again just 50% rise, and then if you still control, your diet, and you're good with your exercise, I mean, you will never get it.
Yeah.
So yes, it does make you more prone if you're.
It also increases your risk of like birth defects, like chromosomal abnormalities. And why is that? The egg is bigger.
But then having said that, even young females have Down syndrome. It's not that, you know, that the young, we've had 20 years old also who have Down syndrome.
Yeah.
There's
I mean, I think
like
for me what was reassuring was that, you know, it was a 1 in 1,000 chance when you're like 20 something, and it's a 1 in 800 chance. I mean, I'm just
the risk keeps going up. It's even higher if you're more than 40 and you can see.
But 1 in 800, I can, you can take that chance.
Yeah, you can take that chance.
It's okay, guys. We don't need to worry because Namrita just delivered a 44-year-old woman's child recently, so it's fine.
Yeah, she was 44, who conceived spontaneously.
Okay.
And it's not like she got married late.
Yeah.
This patient of mine got married in her probably late 20s or early 30s. They never wanted to have a child.
Yeah.
And probably like, I don't know, in the last 1 year, you know, when she was like 43, they just had this thought that, okay, why don't we try, and, you know, if we have it, we have it. It's not that they were desperate to have a baby. And she conceived spontaneously. And in fact, she delivered vaginally. You know, that's something a lot of women these days don't have. It's not the doctors only, you know, want to go ahead and do a C-section. So there's so many patients who come to us, they don't want a normal delivery.
Yeah, that's true.
Like, doctor, I would like to, you know, in fact, we are convincing them to, you know, you should try. And at our hospital, even if you have had a cesarean, we try and, you know, encourage patients if they can.
After a cesarean.
If they can. So there are certain criteria that need to be met for us to give you a trial of normal delivery.
And what's that criteria for what's it called? Vaginal birth after C-section, VBAC,
So we give them a trial of labor after cesarean section. If it's successful, it's called a VBAC, vaginal birth after cesarean. So this is going to get very technical, but then
it might be useful for people who are sort of tuning in and have had C-sections and might be considering a vaginal birth.
Yeah, so if you've had previous one cesarean section, after previous 2, you have to be more judicious.
Okay.
So you could still, but then it's safest after previous one, low segment transverse cesarean section. Like if you've had a classical cesarean, so it depends on this kind of scar you've got on the uterus, and or if you've had any other surgery, like if you've got a fibroid removed from the uterus or a myomectomy scar where the cavity was open, you don't give them a trial, you know. So, and if then you have to also look into what is the weight of the baby, how many years back was the last cesarean done, what was the indication for that cesarean, was it an emergency cesarean or elective cesarean. So you need to have a consult with the doctor, where the doctor would look into a lot of factors, try to see these factors. It should be a currently asymptomatic pregnancy. There should be no other complications.
What's an asymptomatic pregnancy?
Where you don't have any, like, you don't have any medical disorders of pregnancy.
You don't have
You're not really high risk, you know, for that. So no complication over a complication, you know. So all that, the doctor will see that for you. They'll screen that, and if they feel that you're fit to undergo a trial of labor, they will give you that option. It's not like they're going to force it down your throat. They will give you that option in case you're willing. Then.
And why are women not willing? Because there's something I read, again, because my Instagram feed is flooded with this, but there is a risk of this
rupture.
The rupture of the scar tissue.
So there are two things. There is a risk of rupture, and there's also a risk, it could be a dehiscence. There's a risk of uterine rupture also. There's a risk of dehiscence also, where it's not a complete rupture, but the scar gives way. So there is that risk. But, you know, so when we're giving a trial of labor also, we tell our patients that out of 100, 70 to 75 will deliver vaginally.
Okay.
The success rate is 70 to 75. Now, if you don't deliver vaginally in that 25 or 28% patients, it's not that, you know, you're going to die or there's going to be rupture. There are also normal reasons why you may not deliver. Like for a primary gravido, so first time mother going into labor, she may also not deliver. There could be a severe bradycardia, there could be other reasons, a cord prolapse. It can also happen in this post-cesarean patient, right? So those chances are also considered, that those things can also, or you may not progress. There could be a failure to dilate. Like even in a first time mother, you may not dilate, the cervix does not open.
That happened to me.
How do we deliver? So if the cervix is not open, we can't deliver you. So those factors are also here. And the chance of actual rupture is very low, you know. It is just about, you know, 1.2 to 1.5, which, you know, actually it's actually 0.8 to 1.2. So in 100 women, it is less than 1. So if 100 women are in labor, less than 1 will probably have a rupture or dehiscence. And that also for these women, they're high risk patients. So there is 1:1 ratio of a doctor-patient ratio attending to them. So there is somebody with you all the time. And, you know, there are certain signs with which you can pick up that, okay, probably there is the scar is giving way. And, you know, we try and shift the patient as soon as we pick up that sign, you know. So it's not that it's going to be a catastrophe if it happens. But yes, you have to be very, very, you know, vigilant, and you have to be very, very careful in these pregnancies. But we have delivered a lot of these patients.
Yeah, I'm just sometimes amazed how this happened so frequently prior to like so much medical advancement. I mean, and I think I went into my first pregnancy kind of like being like, oh, it's the most natural process in the world. I'm not going to have any pain because, you know, it is sort of what women are designed to do. We're designed to give birth. And it was only after I experienced the crazy labor pains that I experienced. And then I read later that actually human beings, our pelvises are actually pretty small. So unlike other mammals who have fairly painless birth, human beings actually do have very painful birth, and that's always been the case. So is that true, or am I just...
Yeah, there are also different types of pelvises. You know, not everyone has the same term. There's a gynecoid pelvis, there's an android pelvis. Pelvis are also different types.
So some pelvises have less pain. Some lucky
they're more,
people.
They're more.
What's the one that has the least amount of pain?
Gynecoid
Which one
pelvis.
do I have?
How do we get to know which
How
one?
do we get to know? Is it by the size of the hip?
Yeah, there are a few ways in which
Is
the
it
doctor
who
can
can
tell.
twerk best?
So there are different kinds of pelvises. So there is one gynecoid pelvis which is nice and roomy, so it's easier.
I definitely don't have that.
You know what? So I want to say this because like in archaeology and art history, you go to museums, earliest sculptures of women, whenever you saw a woman with a very small waist and very wide hips, generally they were called the fertility goddess. In fact, in the Indus Valley civilization or the Harappan civilization, a lot of goddesses, especially the ones that were found around the Mohenjo-daro Harappa sites, a lot of goddesses were found, you know, elaborate headgear, big waist, tiny waist, big hips, tiny waist, and commonly called fertility goddesses. How would we know that? We don't know that because we can't read the script, or we don't know the language, or even if it was a language. but generally called fertility goddess because of this wide hip, you know. So is it that the wide hip signifies easy birth?
Kind of, you could say that as a layman, yes. But then you also need to do an internal examination to see that if it's actually the gynecoid pelvis, because that's the pelvis. But yes, for a layman, it does, you know, it would generally probably be a gynecoid pelvis. But we do a pelvic assessment also to see.
You better hope you have that one.
I think they must be calling her the fertility goddess because she just produced many children. And she's like, girl, you got it. You know?
And is it true that your second labor is usually a little faster and easier?
Supposed to be. Yeah, it is because, you know, for multis, they say it's easier. But but then having said that, there are always exceptions where I have women, they're like, oh, the first labor is much easier.
Just trying to tell myself at least the second one is going to be easier than the first one.
But yeah, I'm sure you're going to be fine. So how many months are you into your pregnancy?
I am due in October and we're in August, so started my third trimester recently. So now I have to start thinking about the birth.
And the months after
well, at least I have the epidural. I mean, thank God I live in an age where like medical advancement has reached the point where like they can take my pain away. Because I actually went into my birth with my daughter thinking that, oh, I'm not going to need pain medication. I have a high threshold of pain and like human beings are designed to do this.
What did you do, Gayeti, then?
I like became an epidural junkie. I like literally started begging them to like just increase that epidural.
So you took epidural the first time?
I did.
And do you think it helped you?
It actually helped my pain, but I think it stalled my labor. So it was one of those, you know.
Also know that she's a hypochondriac. So maybe even just the fact that she's taken maybe.
No, it definitely gave me a lot of relief, which is why this time I've actually brought a doula on board as well, because I need like some mental coaching to be able to delay that epidural. Because what happened to me in the first, I mean, to TMI, I don't think anyone in our audience cares, but what happened was that because the pain for me was so unbearable, I took that epidural too soon.
Okay,
and I think that actually stalled my labor. So then I had to take a lot of Pitocin to progress, for the labor to progress. So I'd rather avoid that situation and try and just delay the epidural. But I need like maybe a doula, because my husband and my mom were saying don't take it. And just because they were saying don't take it, I was like, I am taking it right now. So I feel like I need like that mental fortitude.
That really helps.
That
really helps. Because if you have and you have somebody who helps you, and also if you do your exercises, and you know, if she can make you do some exercises even during labor, that also helps the baby come down.
Yeah. So now we're kind of like running out of time. Anica, do you have any parting questions?
No, I think this was great. This was greatly eye-opening, and I think one of the things that I really want to take back with me is what you said, is that you know, women are very strong because our bodies are built to sort of produce and create and give life, but it's still every month it's still hard, man. Those hormones, I'm feeling them. I'm so aware of that. So thank you for like helping me with all my questions leading up to it. That was really wonderful.
I'm glad you found that useful. But one thing I would like to, because I think that we started with teenage girls and what they can do, so that's one point I wanted to make. I would like to use this opportunity to highlight that I think all young girls, and I think mothers who are mothers, I mean, or mothers of young girls, your daughter hasn't reached that stage yet, but from the age of maybe 9, all girls younger than 15 should get their cervical vaccine shots. Because it can prevent cervical cancer. And we have our own vaccine also, which is made in India, Cervivac, which has come in now, and they're also planning to make it a part of the universal immunization program, where they're trying to, in future, implement it in a way that the children will get that, the girls will get that vaccine in school. And in fact, this shot is not only for girls, it's even given to boys. In Australia, they've already started giving it to boys also, because it not only protects you against cervical cancer, it also protects you against anal warts, which even the boys can get, right? So, but it's just that India, because, I don't think, first we need to have enough stock for the girls, then probably we'll try and include the boys. But then this is something I would like to highlight, that girls who are younger than 15 years should get, and at that age you just need 2 shots. And so yes, that's something.
When we grown up, we need like 3 shots.
Then you need 3. So, and it's ideal
older,
to get.
It's less effective.
Yes, it's ideal to get it before you're sexually active. But still, less than 26, you should really get it. But in India now they've also increased their limit to 45. That you know, even if you're up to 45, you should still take it.
Yeah, because he was saying that at every age it reduces the risk.
Yeah,
to some
so
degree.
the younger you are, the better. And if you're not exposed to HPV virus, the better it is for you. But still, regardless, get the vaccine. And also remember that if you've got the vaccine, it does not spare you from not getting your pap smear.
Yeah.
Like you still need to get the get your screening done.
And so, like, before we part, like, tell me a couple of things that people should definitely do as regular hygiene in their life. Like the pap smear is one of them, the cervical cancer shot is one of them.
Yeah. And also what they should do is not unnecessarily do vaginal douching and try and wash. So sometimes a lot of women also feel that, you know, they don't feel clean down there, and they feel that they should clean it with soaps or perfume sprays, and you know, all that should be completely avoided. Vagina is self-cleansing. You don't need to use perfume sprays. All you need is normal water, normal tap water, and clean your vagina with it. The outer part, the vulva, that you still need to clean, but inside you don't need to clean it. Vagina is self-cleansing, so you don't need all that.
Okay.
That's a very important part of maintaining your vaginal health. And and practice safe sex practices. You know, those should be adhered to. And of course, and if you are sexually active, maybe try and get on the pill or use some form of contraception that you find best for you. You should go speak to your gynecologist.
And contraceptives have a lot of sort of stigma also associated with them. At least from like when I was in college and I was in school, and we were hearing about it, a lot of people used to complain about how hormonal that makes you, and sometimes it even helps you with your skin and hair. I remember one of our friends used to tell me, oh, I don't really take it for contraception, I use it for my skin and hair.
Yes, it does. So it does help to clear out your skin, and that's a particular type of contraception. So where one of the components, you know, generally these oral contraceptive pills are a mix of 2 pills. So it depends. There are also 2 types. You know, you can have estrogen plus progesterone pill or only progesterone pill. So we have these pills where a particular combination helps you with your skin also and your hair, which we prescribe for PCOS patients as well. But you know, the real secret to a good skin or good hair is again internal. Like, you know, if you're exercising, sleeping on time, avoiding junk food, again it all boils down to your lifestyle, avoiding stress. All that is going to give you, you know, good skin. You don't need to start taking pills just for this purpose. And a lot has to do with a healthy gut. There's a lot of talk on that. So it's again a very, I think your lifestyle choices make a huge difference in, you know, how you look and you feel.
I think we have to get you back for another segment, because one of the things that I really wanted to talk to you about, maybe we can talk about it later another time, is IVF for couples, you know, and the choices and the time and the process. It can be quite intense for some and a choice for some. So I'm sorry we did not get enough time to talk about it. And also there are so many laws and legal ramifications to this evolving sort of medical practice as well in India. And I think maybe it's good reason that we did not, because there's just so much to talk about.
I'm telling you, we can't run out of questions for, I mean, you put women above the age of maybe like 12 in a room with a gynecologist, and you're going to have probably unending conversation, because these conversations don't happen enough, you know. It's usually like
we need to normalize this
and
have more
normalize this. And I also feel that sometimes when you go and meet your doctor, you just get a very little amount of time with the doctor, and you have just so many, like, I know I get so overwhelmed because I have so many questions. It's like blah.
I know, and you're kind of like, okay, my questions are not a priority. You probably have like a woman in labor or something, you know.
Exactly how I feel.
But you know, I don't think patients should feel that way, because if the doctor has an emergency, they will not attend to you. They know what is important for them. So when you go to meet a doctor, let them decide, you know. So don't take the onus on you for their time, that, you know, you're being considerate. You speak your heart out, because that's your one opportunity.
I've also experienced a doctor who's just generally not that encouraging as you are right now, and just give very sort of simplistic answers, and they don't explain the problem to me or explain how I may be thinking about it the right way or the wrong way or whatever.
So I think that's something very, very important, soft skills, and also that's where empathy comes in. I think it's important for a doctor to also be empathetic and give the patient their time, because that could be the only time the patient, that lady has come to you. Especially I'm talking about the low social strata. That's the her only opportunity when she's meeting a doctor.
Yeah.
So when I see a patient, I think about that that maybe that's her only time when she's got, she's come to see me, and she may never see a doctor again.
Yeah.
Especially for educated patients, for people who have money, they can afford, and they may even, do doctor shopping from one doctor to another. That is okay. But I think so I think that somewhere that change, maybe even doctors have to bring in their attitude and maybe be more friendly.
Yeah. I mean, yes, and I don't blame the doctors. I remember I read a Brookings report a long time ago where they did a calculation as to what is the average time a doctor spends with a patient, and it came down to 45 seconds.
Really?
Yeah.
I mean, some of and that's no bearing on my doctor.
45 seconds is really? Okay.
Yeah, but that was a gross average, obviously. And especially they went to public sector hospitals, right? Like an AIMS or a Safdarjung hospital, where there is a line of patients and free treatment going on. And it is also the doctor's duty to see as many patients as possible, because there are several cases, which is the usual effect of a highly populous country like India, right? These things are going to happen. But yes, I do hear you when you say the doctor needs to be empathetic over a period of time, because I do imagine the doctors may need a lot of therapy also after everything that they see. Like cops and doctors, they should all have the best therapists.
Yeah.
Like I feel like the ideal therapist should go to them first and then come to the others,
Yeah.
And therapists need therapists sometimes.
A therapist need a lot of therapists.
There are lots of shows with
Therapists might need psychiatrists,
Unending loop.
Yeah.
But thank you so much, Namrita. It was super helpful.
My pleasure.
And we have tons of more questions.
And you must promise to come back again.
We'll do a part 2.
Yeah,
sure.
Yeah.
All right, everyone. Thanks for tuning in, and we'll catch you next time.